Now let me discuss the another group of drugs which will antagonize the RAAS pathway. The other group of drugs which will antagonize the RAAS pathway is AC inhibitors. So if you take these AC inhibitors, which are nothing but the angiotensin-converting enzyme inhibitors, what these particular group of drugs will do? These particular drugs will inhibit the ACE enzyme, right? They will inhibit the ACE enzyme, or they will inhibit what is called as kinase 2, right? They will inhibit the kinase 2. Now once this particular ACE enzyme is being inhibited, then remember the angiotensin 1 is not being converted to angiotensin 2. Alright, angiotensin 1 is not being converted to angiotensin 2. Now, what is another consequence is, as I have said you, the enzyme ACE, it is useful for breakdown of bradykinin. Right, as I have said you, the enzyme ACE, it is required for the breakdown of bradykinin. Now, with the help of AC inhibitors, we are inhibiting the ACE enzyme itself. So thereby what will happen to the bradykinin levels? So by the usage of these particular drugs, the bradykinin level increases. Right, by the usage of these particular drugs, the bradykinin levels, they are being increased. Now this particular bradykinin, what it has the vasodilatory action. Right, this bradykinin, it is having vasodilatory action. Alright, now what I have said you, this particular AC inhibitors will inhibit the ACE enzyme, thereby the angiotensin 1 is not converted into angiotensin 2. Now, so these drugs, what they will do is, they will decrease the action. Remember this point, these drugs, they will decrease the action of angiotensin 1, but they will not decrease the angiotensin 2 which is already being formed. This is an important point what you need to remember. This angiotensin converting enzyme inhibitors, they will decrease the action of angiotensin 1, but they will not decrease the action of angiotensin 2 which is already being formed. Now if you take the drugs which are included in these particular AC inhibitors, the drugs include captopril, enalapril, lisinopril, and then we have ramipril, perindopril, then we have trandolapril, then we have fosinopril, and then we have moxapril. These are the compounds in this particular AC inhibitors. Now, you take captopril, and let me try and tell you what exactly is the difference of captopril with other AC inhibitors. Remember, this captopril. So let me tell you the important differences between the captopril and the other AC inhibitors. So you take the captopril. Captopril, it is the less potent AC inhibitor compared to all other AC inhibitors. Next, captopril, it is having the fast onset of action compared to other AC inhibitors. And captopril, it is having a short duration of action. Right, it is having short duration of action. And the other important point is, this captopril, it is having less absorption in the presence of food. Right, it is having less absorption in the presence of food within the GIT. Now remember, because it is having short duration of action and it is having fast onset of action, this particular captopril, it can cause postural hypotension. Right, it can cause postural hypotension, which is not seen with other AC inhibitors. This is a very, very important point, right? Captopril, it is having fast onset of action and short duration of action. Because it is having fast onset and as well as the short duration of action, it can cause the postural hypotension. This postural hypotension is not seen with other AC inhibitors. Next, now you take all AC inhibitors, they are prodrugs, right? Majority of this particular AC inhibitors, they are prodrugs. But exception to this is, right, exception to this is captopril and lisinopril. So if you take captopril and as well as lisinopril, these two, they are not prodrugs, right? These two, they are not prodrugs. Whereas, for example, you take other drugs like enalapril, right? For example, you take the other drugs like enalapril. This particular enalapril, it has to be converted to its active metabolite, that is called as enalaprilate, right? Enalapril, it is converted to its active metabolite, which is called enalaprilate. So because this enalapril has to be converted into its active form, that is enalaprilate, that is the reason why this enalapril, it is slow acting, right? That is the reason why this enalapril is a slow acting drug, all right? Whereas your captopril is already in active form, so that is the reason why it is having the faster onset of action. Now, this particular enalaprilate, this is being available as a separate drug, right? This enalaprilate, it is available as a separate drug, and this particular enalaprilate, it is used in case of hypertensive emergency, right? It is used in case of hypertensive emergencies via intravenous route, right? Via intravenous route. Now, let me discuss the uses of AC inhibitors, right? So these are some of the points of the AC inhibitors. Let me tell you the uses of these particular AC inhibitors. Number one, if you take the uses, it is used in case of the treatment of hypertension. This is the first and foremost use of the AC inhibitors. Next, these AC inhibitors, they are also used in the treatment of the congestive heart failure. Why are they used in treatment of congestive heart failure is because whenever you are using AC inhibitors, angiotensin 1 is not converted to angiotensin 2. So if angiotensin 2 is not formed, then aldosterone is not formed. Now, what did we discuss? Aldosterone, it will cause cardiac remodeling. Because aldosterone will cause cardiac remodeling, we don't want aldosterone being produced in patients with the congestive heart failure. In congestive heart failure patients, there is compensatory increase in aldosterone production, all right? So we want to suppress that compensatory increase in aldosterone production. So for that, we use AC inhibitors in patients with congestive heart failure, which will suppress that aldosterone release, and thereby it will prevent the cardiac remodeling, all right? Next, these drugs, they are also used in case of evolved myocardial infarction, right? They are also used in the treatment of evolved myocardial infarction. Next, they are also used in certain complications of diabetes, right? So in which particular complications of diabetes they are used is, they are used in the treatment of diabetic nephropathy, and they are also used in the treatment of diabetic retinopathy, all right? Next, they are used in the treatment of scleroderma crisis, right? They are used in treatment of scleroderma crisis, all right? So these are the uses of the AC inhibitors. They are used in hypertension, they are used in congestive heart failure, used in case of evolved myocardial infarction, diabetic nephropathy, diabetic retinopathy, and as well as scleroderma renal crisis. Now you see here, in the uses of these particular AC inhibitors, I have said you that it is used in the treatment of diabetic nephropathy. Now, what is the purpose? Why we have to use in these patients with the diabetic nephropathy is, these AC inhibitors, they will reduce proteinuria right? They will reduce proteinuria in these patients with the diabetic nephropathy. Now let me tell you the mechanism how they will reduce the proteinuria in patients with the diabetic nephropathy. Now for example, if you see this as the Bowman's capsule, now within this Bowman's capsule we have the afferent arteriole, and then we have the glomerulus, and then the efferent arteriole, and then the efferent arteriole. So this is afferent arteriole and this is the efferent arteriole. Now you take your angiotensin 2. The angiotensin 2, what it will do is, it will cause the vasoconstriction of the efferent arteriole. Alright, angiotensin 2 will cause the vasoconstriction of the efferent arteriole. So physiologically also there is production of angiotensin 2. That physiological production of angiotensin 2 will cause the efferent arteriolar vasoconstriction. Now when efferent arteriole, if it undergoes vasoconstriction, then the amount of fluid which is entering from glomerulus to the efferent arteriole will be reduced, because the efferent arteriole is under vasoconstriction by your angiotensin 2. So that is the reason why the amount of the fluid which is moving from glomerulus to the efferent arteriole will be reduced, and thereby what will happen to the glomerular pressure? The glomerular pressure increases. So whenever there is increase in the glomerular pressure, there is more and more glomerular filtrate. So in that particular glomerular filtrate, more and more proteins, they are also being excreted out within the urine. So remember this point. Whenever angiotensin 2 is acting on the efferent arteriole, there is increase in the intraglomerular pressure, and thereby there is increased amount of proteinuria. Now when you are using this particular AC inhibitors, right, when you are using this particular AC inhibitors, there is no question of the formation of angiotensin 2, right? There is no question of the formation of angiotensin 2. Now when angiotensin 2 is not formed, there is no efferent arteriolar constriction, right? If angiotensin 2 is not formed, there is no efferent arteriolar constriction. So when there is no efferent arteriolar constriction, there will be efferent arteriolar dilatation. So thereby what will happen? The fluid from glomerulus can easily enter into the efferent arteriole, and thereby the intraglomerular pressure reduces. Once the intraglomerular pressure reduces, the proteinuria from glomerulus to the Bowman's capsule will be reduced. So this is the mechanism how in diabetic patients the AC inhibitors will reduce the proteinuria. So remember this point, reducing proteinuria which is being done by AC inhibitors is not only done in diabetic patients, even in case of non-diabetic renal disease. Remember this point, even in case of non-diabetic renal disease, this particular AC inhibitors will reduce the proteinuria. Alright, next. The next use I have said you that it is used in case of scleroderma renal crisis. How these ACE inhibitors are used in case of scleroderma renal crisis is, remember this particular scleroderma renal crisis, it is being mediated, right? It is being mediated by angiotensin 2, right? This scleroderma renal crisis is being mediated by angiotensin 2. Now when you are using these AC inhibitors, there is no formation of angiotensin 2 at all. When there is no formation of angiotensin 2, there is no scleroderma renal crisis at all. So in that way, these AC inhibitors are used in the treatment of scleroderma renal crisis. Now, if you take the adverse effects of these particular AC inhibitors, right? If you take the adverse effects of these particular AC inhibitors, the most frequent adverse effect associated with this particular agents is dry cough. The other adverse effect with this particular AC inhibitors is angioedema. Now both dry cough and as well as angioedema, both of them, they are due to elevated levels of bradykinin. right? They are due to elevated levels of bradykinin. All right. Now you take this particular dry cough. This particular dry cough, they can be reduced by using iron supplements, right? This dry cough can be reduced by using iron supplements. They can also reduce by using aspirin. They can also be reduced by using this particular aspirin. All right. Next, remember this particular ACE inhibitors, the other important adverse effect is they can cause hyperkalemia, right? They can cause hyperkalemia whenever they are used along with potassium sparing diuretics. Right? Whenever they are used along with potassium sparing diuretics. Right? So these are the three important adverse effects with these ACE inhibitors. One is dry cough, angioedema because of increase in bradykinin levels, and they can also cause hyperkalemia whenever they are used along with potassium sparing diuretics. So this is about your ACE inhibitors. Now let me tell you the adverse effects in a mnemonic form. Now let me tell you some of the important points about the ACE inhibitors in the form of a mnemonic, that is captopril. That is captopril. C stands for these ACE inhibitors, they will cause cough. The word A stands for these ACE inhibitors will cause angioedema, right? Both of them, this cough and angioedema, they are mainly because of increase in bradykinin levels. Next, P stands for most of these particular drugs are prodrugs except for your, right, except captopril and lisinopril, these are the prodrugs. And remember, these drugs, they will cause taste disturbances. These drugs, they will cause taste disturbances. Now, these drugs, they are mainly associated with orthostatic hypotension. Now, which is that particular drug which is associated with orthostatic hypotension is mainly your captopril, because this captopril, it is short acting and as well as fast acting. That is the reason why it is associated with orthostatic hypotension. And particularly whenever you combine the ACE inhibitors with diuretics, then the incidence of orthostatic hypotension will further increase. Now, how will you define this particular orthostatic hypotension is whenever the individual moves from the supine position to the standing position, after 1 minute if you check the blood pressure of the individual, if the systolic blood pressure falls more than 20 millimeters of mercury, or if diastolic blood pressure falls more than 10 millimeters of mercury, right, fall in systolic more than 20, fall in diastolic more than 10, that is suggestive of what is called as orthostatic hypotension. All right. Next, now you take this particular P, that is pregnancy. Remember, these ACE inhibitors, they are contraindicated in pregnancy. Right, remember this point, these ACE inhibitors, they are contraindicated in pregnancy. All right. Next, these ACE inhibitors, they are also contraindicated in case of renal artery stenosis. Right, in case of bilateral renal artery stenosis, these ACE inhibitors are contraindicated. Next, these ACE inhibitors, they are also contraindicated in case of increased potassium, because I have discussed that these ACE inhibitors will cause hyperkalemia. So that is the reason why these ACE inhibitors, they are contraindicated whenever the individual is having hyperkalemia. Next, if you take the L, these particular drugs, how do they act? They will act by lowering the formation of angiotensin 2. Right, they act by lowering the formation of angiotensin 2. Right. So this is like a nutshell revision of the entire ACE inhibitors with the mnemonic, that is captopril. right? C stands for cough, A stands for angioedema, P stands for they are mainly prodrugs except for your captopril and lisinopril, and they will cause taste disturbances. They are associated with orthostatic hypotension whenever they are used along with diuretics. They are contraindicated in pregnancy, they are contraindicated in bilateral renal artery stenosis, and they are contraindicated wherever there is increased levels of potassium, and the mechanism of action is by lowering the levels of angiotensin 2.